Hello everybody, this is Mr. Romano again. I am now reviewing the Phobias unit of the Abnormal Psychology section of A-Level Psych. This is my third time recording the video because the sound quality was not too good, so I might go through this a little quickly. I invite anyone to pause any of the slides. As usual, my slides don't have a lot of information printed on them because I believe in taking things in digestible bites. So again, feel free to pause stuff as you need. All right, we started on Monday, the 16th of October, and I started with this relatively simple question. Explain in your own words what is meant by the terms treating phobias. I started with this question because I wanted to gauge what people already knew about phobias. The word phobia is used in pop culture. However, of course, we need something that's a little bit more clinical and more aligned with the DSM. All right, so most people know that already that phobias are fears, but what makes a phobia different from a fear? Okay, so if we go to the marking scheme here, we could kind of reverse engineer what phobias are. And they are defined by three key adjectives: irrational, intense, and persistent. Now, notice that the question says in your own words, and there's always some ambiguity about what that actually means. Don't make up your own language. It seems that Cambridge wants you to use, layman terminology. However, don't be afraid of memorizing some stuff that sounds a little bit more textbook, a little bit more filled with jargon. If you don't say irrational, intense, and persistent, maybe say things that are synonymous with these words, maybe illogical, powerful, enduring, long-lasting. One student had said that a phobia is a fear that is debilitating. It causes disruption to their daily lives, and that's always true for any sort of abnormal condition. And sure enough, if you go to the DSM, the fifth criteria for a phobia does indeed say that it does interfere significantly with a person's normal routine. So if you look at the other criteria, it sort of aligns with what we already said. It's excessive. It provokes anxiety immediately. There's no delay between seeing the stimulus and having the anxiety. And I think point C is actually quite noteworthy. The person recognizes that the fear is excessive or unreasonable. So unlike some other conditions, the person who actually suffers from a phobia actually does recognize how illogical they're being. For example, today I showed pictures of small clustered holes to illustrate trypophobia, and I gave some warning to some students not to look at the slides if it makes them uncomfortable. And one girl decided to look at the slides, and she was upset, not necessarily because of the phobia, but because rather that she knew she was having an irrational reaction. So it's just as distressing that it's irrational as it is that it is invoking or provoking some sort of fear. And like other things in the DSM, the criteria will also mention things that it should not be confused with. So for example, if the person is upset at germs or dirt, feels anxiety associated with these things, it might be better to diagnose them as OCD rather than germophobic, because maybe that diagnosis will be more beneficial to them to address their certain aversion to germs. So we started with the two early theories about what causes phobias, and part of the reason why I went to phobias out of order rather than dealing with general anxieties first was I realized that when we had the last assessment, several students were not able to very clearly give some of the theory behind classical conditioning, which is the basis of behaviorism. So when I asked about aversion therapy and talking about addiction and how to handle maybe something like a drug addiction or alcoholism, many people were not able to identify the UCS, the UCR, the CS, and the CR. I think I made too much of an assumption about what you guys learned last year about the little Albert experiment from 1920. This experiment was conducted by Watson and Rayner. These are some names that you probably should know. They're rather famous for 20th century psychology. Of course, famous does not equal good. Sometimes famous is just a matter of being early or first. So they were one of the first to try to empirically prove that there was some sort of conditioning involved with fear. And I asked students if you remember what the unconditioned stimulus and the unconditioned response were, and then what the conditioned stimulus and the conditioned response were. A good way to remember unconditioned stimulus and unconditioned response is that these are things that you do not have to be taught. These are sort of like natural reactions. Right? So, for example, in this study, we don't have to be taught that loud noises are things that cause discomfort or distress. I think most of us naturally dislike loud noises. So that being said, the unconditioned stimulus is the loud clanging sound. Unconditioned response is the distress. The neutral stimulus is the mouse, or the rat, excuse me, that elicits no response yet. But if we keep pairing the loud sound with the approach or the petting of the animal, eventually those two things will become associated with each other, and eventually the child should have a distressful reaction to the rat. Here is another pictorial representation of what happens to Albert. Okay, again, the rat starts off as neutral, and in conditioning, the neutral stimulus will eventually become a conditioned stimulus if you keep repeating the pairing. In the little Albert experiment, that fear eventually became generalized to other things that shared characteristics with it. So, for example, a bunny rabbit also is furry and also is an animal, might also elicit the same fear. And again, this is called generalization. In the Watson and Rayner experiment, I believe the rabbit was not even white. It was a brown rabbit, but it still elicited a distressful reaction. Watson also exposed the child to stuffed animals, which elicited crying, and he eventually put on this creepy Santa Claus mask, which again had the same sort of reaction. One thing to keep in mind with this experiment is that if you look at the video of it, which is available on YouTube or anywhere, you'll get the impression that this was done very quickly. However, this was sort of longitudinal. It was, I believe, a 3-month period of conditioning and then testing to see if there was extinction of the fear, which I believe there wasn't. All right, I also had students identify UCS, UCR, CS, and CR in some novel situations. And again, the UCS and the UCR are things you don't need to be taught. So in this case, burning yourself is not something you need to be taught is a bad thing. You just know it is already. However, you might start to associate the image of fire with the pain you felt earlier in your life, and it might lead to the same reaction that you initially had when you got burned. Like I said, UCR and CR are often the same reaction or similar reaction. This example might hit home for some people because you might have experienced a terrible car accident, or you know somebody who has, and after that experience, the way they react in a traffic situation might be impacted by that one accident. Sometimes it only takes one moment to condition something. It depends on the severity of the situation. So on the previous example, the sound of ice hitting a glass might indicate, oh, dinner's ready, and you might get hungry. But that can't just happen once. That usually has to be conditioned over time. Maybe there's a few days or a few weeks where you hear the glass hitting the ice and you're like, oh, dinner's almost ready. It's not something that's going to be a one-time thing. But with a car accident, it's so traumatic that the conditioning happens immediately and is very, very difficult to extinguish. Okay, so again, these are just some terms you might want to use when discussing behavioral theories of phobia. Don't use operant conditioning. This is all classical conditioning. If you're talking about unconditioned stimulus response and things like that, you're dealing with old school Pavlov. Moving even earlier, Okay, Watson and Rainer was 1920. Moving to the early 20th century, we have Freud. And simply put, Freud and psychoanalysts viewed phobias as the manifestation of an internal conflict. And that internal conflict is usually between the id and the superego. For those people who don't remember, the pictures should be a guide for what the id and superego are. The id is the one who's tempting you. The superego is the one who's, being the law-abiding citizen, if you will. So, for example, eat the chocolate cake is the id. Do not eat the chocolate cake is the superego, and then the ego is the great moderator in the middle, who maybe says, take a few bites of the chocolate cake. Of course, that's a very benign example. A less benign example would be, I want to hook up with my coworker, but she's married. The id would say, go for it. The superego would say, that's wrong. And the ego would say, oh, I'll just be her Facebook friend or whatever. Now, these kind of conflicts are usually things that happen in our adult life. So to put it in the terms of phobia, Freudians often believe these conflicts are more important in our early life. If we look at the Hans study, we could see this in more detail. Okay. I'll skip this. So hopefully you remember some of the details from the Little Hans study from 1909 that was done in the AS year. The unconscious anxiety, which is usually socially unacceptable, or if you're a child, you lack the ability to what's the word? To call it by its name. Okay, this is something that's internal and not necessarily something you're completely aware of. It's unconscious. So in this case, it was the desire to be romantically involved with your opposite sex parent. And in the case of little Hans, he externalized this, both this desire and his rivalry with his father as being afraid of horses. So in psychoanalysis, a fear is just a symbol for something that's much deeper. So you're not actually afraid of horses. Maybe you're afraid of your father. And in this little Hans study, Freud points out some physiological similarities between the horse and the father, not just the genitalia, but maybe the blinders around the eyes equal the glasses of the father, or the bridle harness over the nose equals his mustache. And in this case, too, there was some generalization of the fear. I think Freud mentions that Hans is also a bit freaked out whenever he sees like a carriage being pulled by a horse. So he associates the carriage as well with the horse. One of the basic laws of psychoanalysis is that you don't treat the symptoms, you treat the root causes of the symptom. So unlike CBT, which we talked about in the previous unit, which deals with the present, psychoanalysis will deal with the root causes that exist from childhood. So they believe in what's called symptom substitution, which simply means that if you treat the fear of horses, you're not actually helping the client, you're just giving him an opportunity to redirect his conflict to something else. So maybe I've cured you of your fear of horses, but now all of a sudden you're afraid of clouds, or something else that's external. Okay. The next day we just revised identifying UCS, UCR, and things like that. If you want to pause here, you may. Okay, again, I gave you the same question as before. Phobia is irrational, intense, and persistent. Here's a new question that revises the Freudian explanation. What is meant by the psychoanalytic explanation of phobias? Again, it's a conflict between the id and the superego, and it is a displacement of an internal conflict onto an external object. Again, here we have in your own words. I'm always very doubtful of that phrase, in your own words, because I do think they want some jargon in these answers. So to sum up, if we were to have a situation where a woman comes into a doctor who's afraid of birds, she has ornithophobia, a psychoanalyst might say, oh, well, the bird represents your fear of intimacy because flying is a metaphor for sexually adventurous behavior. something like that. It's very colorful and very metaphoric, and but the problem is, again, it's not empirically supported with evidence. A behaviorist, however, may look to see if you had a direct traumatic experience with the bird. So to revise this, we watched a few minutes of Big Bang Theory, in which Sheldon does indeed suffer from ornithophobia, and Blue Jay appears on his sill. And if you watch the episode, he explains why his fear developed. It first started with a hummingbird, then moved into a chicken, a magpie, a parrot. So we can see from this episode, this aligns more with a behaviorist interpretation of how fears form. He doesn't have a direct experience with a blue jay, however, so we could easily say that Sheldon generalizes fear to all birds. Okay, then we moved on to therapies, and with therapies, there's one name I'd like you to know, and that's Joseph Volpe. He was a South African psychiatrist in the mid-20th century, in a time where Freudian psychology was still dominating. He was quite innovative in that he did something that was against the grain of prevalent psychology when he dealt with war veterans for post-traumatic stress disorder. He came up with a system to handle fear counter-conditioning, and that's called systematic desensitization. What that really means is that you build up a hierarchy of what makes the client feel afraid, and you step by step introduce the stimulus to the point where the person can handle being around the feared stimulus. And this is done based on the principle behind this is called reciprocal inhibition. Reciprocal meaning going both ways, inhibition meaning inability or stopping something. And really all this fancy term means is that you cannot be simultaneously afraid and relaxed at the same time. They're mutually exclusive. It's impossible to be both. I'm going to skip this real quick, come back to it later. So if we were to use an example of systematic desensitization, you might start off with something as benign as a picture, but it still elicits a fast heart rate, it still elicits fear. After that has been handled, maybe you get the client to go through some relaxation techniques. Then maybe a week later, she's ready to hold the picture in her hand. Maybe the next session, you show her a dangling toy spider, and eventually she holds the toy spider. However, the last three images on this example, there's a real spider, and this is called an in vivo exposure. In vivo is Latin for in life. So you're actually getting to experience the stimuli directly. So it gradually builds up to this point. The key word in systematic desensitization is gradual. You don't want to start the person off with the spider. If you do that, that's not systematic desensitization. That's another phenomenon, or another treatment, called flooding. Another way to describe this type of exposure therapy is to call it counter-conditioning. When you associate relaxation with the fear-inducing stimuli, you're undoing the connections that were made. So this is why it's counter-conditioning. I asked students to create their own hierarchy of anxiety for phobia. And again, I say do not start with in vivo because that's not systematic desensitization. So be careful there. Don't confuse the two. All right, I gave students a list of some common and uncommon phobias. Some here I'm not even sure are real. For example, xenophobia is the fear of Chinese people and things. I'm thinking maybe that's just a clinical way to excuse somebody's racism. I'm not quite sure. If it's real, I'll be amazed. I was in China for a while. I've never seen anyone afraid of Chinese people. But then again, they wouldn't be in China, so what am I talking about? All right, so there are several examples of anxiety hierarchies, which could also be called an avoidance hierarchy. Two most common metaphors are ladders and thermometers. I would recommend using something like a thermometer because you can give a numeric value to someone's fear. Let me go back here. SUDS is the most common thermometer. It could be in units of 100 or units of 10, and SUDS stand for subjective units of distress scale. Now keep in mind this does say subjective, so it does recognize that like most self-reports, this is going to be subjective. However, it's highly useful in creating a recipe for how the psychologist is going to address your fear. So he might start by exposing you to things labeled at 10 and eventually work his way up to 100. If you are ever asked to give a recipe for systematic desensitization, some students might jump right into step 2 without asking the client to do his homework with the thermometer. Take that extra step. Step 1 will make step 2 a lot easier. Okay, I asked students to give me a short assessment last week. I put these 2 cartoons on there to assess if you could recognize different types of therapies. The cartoon on the left is a great example of flooding. Professor Gallagher and his controversial technique for simultaneously confronting the fear of heights, snakes, and the dark. So this is just flooding. Why do people use flooding instead of systematic desensitization? Well, it's time saving. You just throw people in a snake pit rather than show them cartoons of snakes or use a VR headset for snake exposure. You just immediately get it done. So this is time saving. However, is it ethical? It's only ethical if your client is willing to go through it. Maybe he has to fly on a business trip next Tuesday. He doesn't have time for systematic desensitization. So immediately he wants an in vivo or a close to in vivo experience. So you're going to stick them right onto an airplane right away. The physiological principle behind flooding is that a person cannot sustain high levels of anxiety for long. It has to dissipate eventually. Being stressed takes a lot of physical energy, and so it just means that if you're in the room with the snakes, you have to eventually, through the laws of physics, not be able to maintain that level of stress for long. Okay, here are some questions that you might be asked. Explain in your own words what is meant by a case study of phobia. Don't make the mistake of saying a case study is longitudinal. They're often longitudinal. Why is there no marking scheme for this? Huh. Oh, there we go. Usually an in-depth study of a single person. And there are 2 that you should already know from your AS year. Of course, there's Hans and there's little Albert. If you want a different case study, I also have access to this article that is now being used for AS. It replaced the Hans study about a 9-year-old boy who's afraid of buttons. Apparently he had a traumatic experience with buttons falling on him when he was in elementary school. And what this article does differently than previous research is it tries to introduce the notion that a phobia is not just a fear, there's also an element of disgust involved in your phobia. And again, this is on the ACE Psych website if you want to get a copy of this, or you could ask me specifically for a copy of this article. But again, I think most people would probably go for Little Hans or, sorry, I can't find this. Yeah, Little Albert or Little Hans, 1920, 1909. All right, the next lesson took a big left turn, and I'll explain how this relates to phobia in just a moment, but we actually did a practical of a Stroop test. A Stroop test is a very easy test that could be administered with cards or with an app or via computer. Because our Wi-Fi in the school is not too good, I elected to just give you an image of some colors and ask you to conduct a Stroop test. What a Stroop test asks you to do is to name the color of the ink on each card, not to read each card. So you can see the front card is both the word green and written in green. The next card is blue, but it's also written in blue ink. The last card, however, is red. If the person says green, that last card would be incorrect. People tend to slow down when the color and the word are not the same. This is called cognitive interference or the Stroop effect, when you need more time to read words that don't have the same information in terms of its color and its word. Okay, so let me just give you a brief example here using myself. If I were to read these words, I would say, I'm sorry, if I were to look at the color, I would say red, blue, orange, purple, orange, blue, green, red. Then if I go to the next list, I would say green, red, purple, blue, blue, red, green, orange. You may have noticed that the first group of words was read slightly more quickly than the second group of words. And again, this is the Stroop effect of cognitive interference. Now, what the heck does this have to do with phobias? Well, there's one article in our textbook that is cited, and here is the abstract for it. It's called Cognitive Bias in Spider-Phobic Children, Comparison of a Pictorial and a Linguistic Spider Stroop. So this famous replicated study of Stroop experiments was recreated and sort of hacked to include words that were related to spider or things having to do with spiders. Let me skip past all this stuff here. So you could pause this and read this abstract or read the materials used if you want. Essentially, what happened was children who were arachnophobic or diagnosed as arachnophobic or afraid of spiders were reading both spider-related vocabulary and non-spider-related vocabulary. And surprise, surprise, the words that were spider-related were longer to read for them. It took them more time to read those words or to identify those colors because there was some sort of cognitive element that was interfering. They were afraid or there was some sort of slowdown because of their fear. Now, again, going to the textbook, this is all on page 228. It's very short, the cognitive section, but you never know if it's going to be asked. So have both of these cited articles under your belt, if you will. They're not too difficult, especially the DiNardo et al. 1988. That one is pretty easy. The number to remember is 50%, so that's a very easy number to remember. I don't ask you to remember a lot of numbers, but that's a very simple number. Essentially, what DiNardo found was that people who had a traumatic experience with a dog, only half of them actually developed a dog phobia. Therefore, there must be some other element to fear than just behaviorism. There must be some sort of cognitive element. Do they actually associate the experience with all future experiences? How did they logically work through that trauma? So again, it's not just about did it happen or did it not happen, but if it did happen, did I reason through it in a adaptive or maladaptive way? Just because I was attacked by a dog when I was 5 doesn't mean I'm going to have a bad experience with dogs in every time I see a dog. So looking at summer 2014, look at part B. Describe one study supporting the cognitive explanations of phobias. Are you going to choose Kind and Broscott with the spider Stroop task, or are you going to choose DiNardo with the dogs? Honestly, DiNardo is easier to remember, but my problem is that this is a 6-point question. You might be able to get more detail out of talking about Kind and Broscott's study on spider-phobic children. So me personally, I would go for the Stroop test, but I think most students would go for DiNardo because of the easy concept behind it. And sure enough, if you look at the marking scheme, they do mention only DiNardo by name. Okay, one of the last things we talked about was the biological factors for phobias. We looked at this study by Cook and Maneka from 1989 in which they took rhesus monkeys and they brought them up in captivity so they were not exposed to any sort of extraneous things growing up. They had never seen a spider, they'd never seen a snake, they'd never seen a flower, they'd never seen a crocodile, or they'd never seen a rabbit. And they showed these monkeys videos separately. They were independent group design. And the monkeys were tested to see if they would learn to fear something based on the reactions of other monkeys on a videotape. Let me put that more simply. Um, okay, so let's say this monkey saw a video of a toy snake and it was spliced together with a monkey's reaction that was filled with fear. And the next one saw a video of a flower, and again, the same reaction of a fearful monkey. Same thing with a toy rabbit, and the same thing with a stuffed crocodile. What they had found was that monkeys who had seen the toy snake actually did indeed develop a fear of the toy snake. But for those who watched the video of the flower, there was no fear of flowers, nor was there fear of the rabbit, but there was indeed a fear of the toy crocodile. What does this have to do with biological explanations of phobias? Well, it sort of aligns itself with the notion that fears are genetically pre-programmed, that we benefit from having fears. So just like with physiological characteristics, we're taught in biology class that Darwinism is, or evolution is often based on genetically desirable traits that are physical. The same thing is true with psychological traits. So for example, this group of animals fears snakes, this group of animals doesn't fear snakes. Well, guess what? The one who fears snakes might live longer, or they might not die out because they're not thinking, oh, that snake is kind of interesting and cute, let me pet it, and then get bitten and die. So that being said, genetic predisposition or pre-programming is strongly supported as a possible explanation for why we fear things. So fear in this way is a good thing. It's good to have fear. But can genetic models explain all phobias? There are some phobias which don't occur in nature. A good example, again, would be button phobia. I showed some images just for conversation's sake of clusters of small holes. If this freaks you out, you may skip this slide. But it's, one study even predicted or said that there are 16% of our population fears small, tiny clusters of holes. You make of that what you will. Why would this be advantageous for people to actually fear this? I'm not quite sure. If you have a theory, you could put it in the comments below. So that's genetic. I put a picture of Darwin there. Don't mention Darwin by name, just say people who support the genetic explanation would say that pre-programmed fear helps us survive as a species. All right, the last thing with biological that I'll mention is the amygdala. Last year, you guys learned about the hippocampus with the taxi drivers and how that's related to memory. At the end of the hippocampus is the amygdala. It is associated with high intensity emotions, namely fear. It initiates the fight or flight response that we feel when we see a fearful stimuli. And interestingly, it cannot distinguish between what is a real threat and what is a perceived threat. And this sort of links in with cognitive psychology, and I'll show you in just a moment how that works. So the amygdala is often called, or often described as almond-shaped. So I'll use an almond here just so we don't look at any squishy, ugly biological things for those people who are squeamish, and talk about the double pathway that exists in the amygdala. The amygdala has both an ingress and an egress pathway. So for example, if I see a fear-inducing stimulus like a whale jumping out of an ocean, the pathway that gives me that sensory input to my amygdala is very quick, like a nanosecond to get that from my external vision to my internal processing of that vision. So the input pathway is very short and quick. It is a reaction, and it instigates, again, the fight or flight response. However, the output that we get from the amygdala to our cortex, and our cortex is our reasoning center of the brain, where we form cognitions and form logical connections, is slower, and it's longer. So the pathway in is short and fast, the pathway out is long and slow. What does that matter? Well, it shows you how powerful biology is over logic and reason. Remember the Schachter and Singer study last year. When we have some sort of physiological reaction, it takes us some time to evaluate what that actually means. So this is like a very maybe an oversimplification of what fear is, biologically speaking, but oftentimes with biology, you have to isolate one part of the brain or one part of the body to study things empirically. So of course, anytime you talk about something like this, where you're reducing the complexity of fear into one portion of the brain, the easiest evaluation to give is to say that looking at the amygdala as a cause of fear would be highly reductionist. Okay, the last thing to talk about would be blood phobia or hemophobia. Okay, one of the things that makes hemophobia or blood phobia unique to the other phobias that we've studied is that it's closely associated with fainting. What is fainting? Well, let's use some fancy schmancy words and let's refer to what's called the vasovagal response, which is the reason for the most common reason for fainting with blood phobia. There is a connection with the brain with the medulla oblongata, but let's simplify this and let's not worry too much about the brain structure when talking about this. Essentially, the brain signals the large veins in the legs to expand fully, to open fully, which results in blood collecting in the legs at an abnormal rate. So that big differential in blood pressure causes the vasovagal response and you fall down. So that being said, there is a specific treatment that could be used that addresses the physiological nature of fainting that is used for blood phobia that can't be used for other types of phobias because, again, blood phobia is associated with fainting. If you're wondering why the blood collects to the legs, one easy theory is that when we do have the fight or flight response initiated, our body reacts accordingly, allowing blood to flow to the areas of the body where you need to have a reaction. So, for example, if I see a bear in the woods, I might need blood flow to increase in order to run away from that scary bear. That's an oversimplification, but it's the best way I could put it. So there is something called applied tension, and this is a very prescriptive technique that's much simpler to, or not much simpler, but much more detailed in its application than other types of therapies. And why is it more detailed? Because again, it's physiological. It's almost like rather than being a cognitive treatment, it incorporates both cognitive elements and physiological elements. And it just simply is a contraction of your muscles for maybe 15 seconds, holding it there, and then releasing for about 20 seconds. All right, so expand, contract, expand, contract, expand, contract. Tighten, release, tighten, release, tighten, release. And if you keep doing this as you're exposed to the various aversive stimuli, you might have less of a chance of fainting. And the name to associate with this is Lars Göran Ost, or Ost, who apparently is Scandinavian based on all the umlauts above his name. There are lots of articles written by Ost or Ost, and I don't want to overwhelm anybody with these. Maybe as we get closer to exam time in May, I'll start having people get a little closer to these studies. Right now, I think maybe the only one to look at would be the first one on the list. In this study, we have an independent group design where 3 groups are applied respectively 3 different treatment regimens. One group is applied tension, which we just talked about, expand and contract. Another group has something called applied relaxation. And another group has a combination of those 2. To put it simply, those people who just did applied tension had less severity of symptoms in just half the time as the other treatments. So what we can conclude is that all 3 of these are good treatments. However, applied tension is the best treatment. You could save half the time in treating a patient with blood phobia. Okay. The other article just simply says that studies have shown that blood and injection phobias have a lot in common, and maybe there's reason to not differentiate between the two. They might be two sides of the same coin. And here we see that applied relaxation was used to handle panic disorder. This is not important, just skip this, please. All right, so a lot there, 91 slides in, I guess, like a half hour or so. I just wanted to be able to give you that to revise. Wednesday's assessment should be okay as long as you're able to drop some of these facts along the way. There's no evaluation questions. We're going to save the evaluation questions for after Christmas. So don't worry too much about reductionism or nature versus nurture type of questions. Those will come up mostly after Christmas. All right, I'm talking way too much, and I need to grab some water, and I hope you guys do well.